I will quickly like to give the credit to the Nigerians on Tea side, popularly known as NICOT, Ubuntu Multicultural Center. And I will quickly like to acknowledge another association is called NAS, Saxon Deck. Good evening, everyone, and welcome once again to another town meeting. Today, we will be talking about our mental health, the mental health stroke illness in Black community. With me on the program, we have so many experts that we have put together for us to be able to achieve this discussion today. Before I continue, I quickly want to inform us about this. This program, like we normally do, we will record this program and redistribute it to the community through YouTube. I believe we are all comfortable with this. Let me repeat it again. We are going to record this program and redistribute it through to the community through YouTube. I believe we are all happy with this.
Yep.
Thank
Absolutely
you.
fine.
All
Yeah.
right.
Yes.
All right. And we can go on now. Today we'll be discussing about mental health, stroke, mental illness, and its related issues. The mental health of the community is important because people from our Black community often face individual and societal challenges that can affect their access to health care and their overall mental and physical health. In today's discussion, we aim to improve our knowledge and understanding of these issues so that good practice and effective strategies may be implemented. And today we have so many doctors who I always refer them to as the experts among us. And I would quickly like to introduce them to us. I have with me Dr. Ugo Chinwuba. Dr. Ugo.
Yeah, I'm here.
Right. Yeah. You're welcome. And I have with me Dr. Vicky Audu Zekwe. Please pardon me and forgive me about this. I hope you understand. I have with me Dr. Peter. Do we have Dr. Peter Okay in the house? Dr. Peter Okay. All right. He will be joining us later. I have with me Mrs. Shade Shogowawa, who is a community representative. She's very popular in our community. Hello. Hello, ma. Thank you. You're welcome, ma. Dr. Tammy Datubo will be joining us later. He has sent a message to me, so he'll be joining us. Before we continue, I quickly want to use this opportunity as well to give credit to some associations that showed big interest in what we are doing today. I will quickly like to give the credit to the Nigerians on Tea side, popularly known as NICOT, and we have the president among us. Please, who is Sarah Mbama? Sarah Mbama, please, can you? Okay. All right, that's Sarah Mbama for you. All right, that's the president of NICOT. And we have another association called Ubuntu Multicultural Center. The representative is here, John Kabuye.
Hello, nice to see you,
everyone. All right. Yeah. You're welcome. And I will quickly like to acknowledge another association is called NAS, Saxon Deck. So, and all right, we will continue now. All right, because of our time, can I quickly ask all our guest speakers in just one minute to quickly introduce themselves better to us in one minute. And I'm going to start with Madam Shade Shoguwawa. Everybody would like to meet you and they would like to know who you are. In just 1 minute, please.
It probably will be less than 1 minute.
Thank you.
I'm Shade Shoguwawa. I work in the community and I've been working with different communities, really, not just Black communities, working with different communities, trying to help them to navigate the system and in the process, help them to become economically independent. But as part of that process, it's also providing support and advocacy, for the community as well in Tees Valley.
All right, thank you. Thank
you.
I'm
sorry, I'm supposed to say I am married to Dr. Shoguwawa. Oh, sorry, Olatokunbo Shoguwawa, to be precise.
That's good. That's good. Can we quickly move to Dr. Ugo, please?
Okay, my name is Dr. Ugo Chinwoba. I'm a psychiatrist. I work with the Tees Valley NHS Trust. So I'm an old age psychiatrist. And I also do forensic work for the place.
Thank you. I will like to move to Dr. Vicky. Can you hear us?
Yes, looks like there is a plethora of old age psychiatrists on the panel today. I am Dr. Vicky Nzekwe. I'm an old age psychiatrist and I work locally for the Tees Valley's NHS Foundation Trust, same as Dr. Ugo.
Thank you. You're welcome onto the program. And I have Dr. Sam Best Iruje with me. Hello, sir.
Yes, I'm Dr. Sam Best Iruje. I'm popularly known as Best, Dr. Best. I work in rehabilitation and recovery psychiatry. I'm also a pastor and I work across the community, both ethnic minority and the majority group, helping them to discover themselves.
All right, thank you. Thank you. And I have with us Dr. Peter Oke. Dr. Peter Oke, can we see your face and please can you unmute as well? Just in 1 minute, can you quickly introduce yourself in 1 minute or less? Dr. Peter.
Yes, yes, I am with you. Yes,
okay.
Dr. Peter Oke. I work with Lincolnshire Partnership NHS Foundation Trust, inpatient and community.
All right. Okay. Thank you. You're all welcome. My name is Tolachi Dayoba, popularly known as Mr. T. I will be hosting this event tonight, and I have with me Ngozi Silva Ochuba. She will be hosting along with me. Ngozi, please, can we meet you? Hello? Unmute, please.
Good evening, everybody. My name is Ngozi Ochuba. I am a BME navigator with Step 4 Tees Valley. So I work with the Black, Asian, and ethnic minority community in Middlesbrough. And basically what I do is help people get back into education, training, or employment. Basically what we do is we try to reduce barriers to help them get to those points in their life. So.
All right, thank you, Ngozi. All right, thank you. So from here we move on. According to the Equality and Human Rights Commission, an individual from a Black ethnic background is more likely to experience poverty, being unemployed, and to have encountered unjust criminal justice system. These individuals are also less likely to have received the care and support when they need it. So one of the major reasons why we are here is how do we recognize mental health issues in our community? And at what point should we begin to seek help? So these are the issues that we will be discussing today. Because of Dr. Ugo's time, I would like him to quickly, because he has been assigned an issue for him to discuss with us today. Dr. Ugo, can you hear me?
Yes, I can hear you.
Please,
yeah.
can you just give us your presentation, and from there we'll move on. Thank you.
Yeah, I mean, since it's going to be a very short presentation, that will be fine by me as well. So my own topic today is to talk about the signs and symptoms of mental illness in the community, right? So I will be talking about the things that we should be looking out for, and also the person involved should be looking out for, to kind of alert them that they are mentally unwell, okay? So as we are all aware, can you hear me?
Yes.
Okay. I can.
Now, you know, in psychiatry, signs and symptoms are not clearly demarcated as we have it in other fields of medicine, right? Where you can say this is this, this is this, and this is this. In psychiatry, they often overlap. They overlap. So, and because of this, disorders in psychiatry are often described as syndrome. Syndrome is just a constellation, you know, of signs and symptoms that collectively make up a recognizable condition, right? Where you can say you add this, add this, add this, and this is the condition that it becomes, right? So that's how we kind of work it out in psychiatry. Then if we talk about the signs, signs is just any indication of a medical condition that can be observed by others. When we say others, we say objectively observed, right, by others, which is other than that person who has the problem, others cannot, this is what others can observe, right? Whereas symptoms is merely a manifestation of a condition that is apparent to that patient, which means the patient is aware of that, okay? And we describe that as a subjective experience where they can say, I have this, I have headache, I feel this. Because for instance, you can't feel headache for somebody who's got the headache, right? The person can tell you, I have pain here, I have this here. So that's where you can say that's a symptom. So you see how signs and symptoms can be differentiated, right? I mean, in mental illness, we have warning signs which tell us that somebody might be mentally unwell. And I can give you 5 of them, which is what's going to kind of help us understand if somebody is mentally unwell or not, okay? So, for instance, if somebody's got constant anxiety, I'll just name them, but I'll talk about them briefly, one after the other, okay? But constant anxiety, somebody who is frequently having outbursts of emotion, then insomnia, where somebody can't sleep. And we can also say when somebody is aloof or kind of withdrawn, right? That's another thing, if you see that. And or where somebody is having some illogical thinking, where they say the person have abnormal experiences as well. So I will go through them one after the other. And I will start with constant anxiety. Anxiety, I've seen that this period. That's people who are becoming quite anxious because of this prevailing condition, this COVID thing. That anxiety then leads to some mental health problem, and they end up becoming admitted as a result of this. In my team, I've seen a lot of our patients who call in all the time. Sometimes we receive their calls 4 times a day, and this is just because they are very anxious about what's going on, this condition, okay? So sometimes they end up being admitted, yeah. So people could get anxious, right? Sometimes, but however, if this person seems to be anxious all the time, that's a possible sign that the person might be becoming unwell. So the second thing I mentioned is social services. Frequent outbursts of emotion, right? Because people can experience mood swing. I mean, people with mental health problem can experience extreme mood swing. And sometimes somebody can result in where the mood swings from extreme sadness to anger. And you see that happening very quickly. One example is somebody I admitted just 2 days ago. This person gets so angry quickly. You talk, before you know it, is angry, insulting you, calling this one of the bitch, this, even going out to strangle. That's quick emotional change from just being sad to becoming very angry. So that's another possible sign that that person is unwell. But this, in this case, this person was really unwell. Okay. The other thing, again, I said, is insomnia. Insomnia is when people are not sleeping. Usually, we know that normal sleep have a range, maybe between 6 hours to 9 hours. If you're getting that a night, then we call that within normal range. But sometimes people are not sleeping very well. It's very short sleep and so on. And if they see that this is happening to them quite often, where they are not sleeping every night and so on, then that might be a sign that they are becoming unwell. The other thing again is that sometimes people might be sleeping too much, because we could have it the other way, where people just sleep, they are so lethargic, they don't want to get out of bed and so on. That's another possible sign that the person might be unwell, right? The other thing I mentioned again is being withdrawn. Withdrawn is where the person, you might notice that doesn't go out to meet friends, wants to be on their own all the time, doesn't want to go for any occasion, no activities and so on. Although we know that we sometimes want our me time, there are times you just want to relax, right? Or you want to be left on your own, but that's not something that you say this become the thing for you. But where it becomes extreme, where this person is so withdrawn, not going out, keeping to himself, not getting involved with any activities, then that's a possible sign that that person might be unwell, mentally unwell. The last thing I mentioned there is where people do have illogical thinking, right? That's abnormal experiences. It comes in different ways. It could be, there is the one we call delusions, where they have abnormal belief about something, somebody doing something to them. They might have magical thinkings, where they might kind of believe they can do and undo, they can do things other people can't do and so on. And they might have things like maybe hearing voices when nobody's there, seeing things that other people can't see, seeing ghosts, seeing all this. So these are abnormal things happening to the person. And in that case, we can now see that as a possible mental illness as well. So, I mean, in conclusion, what I would say is that mental health is something we know that is treatable. So observing and kind of finding out that this is what's going on, and maybe getting that person to get help, timely help, is very, very, very important, because we know that mental disorders can be cured, right? So getting the timely and the right help for this person is something we should always look at, and maybe ask the person to look for help. Like I mentioned, there are some where the person can observe themselves, where they will tell you, yeah, this is how I am feeling. But whereas there are some where the person won't even know that they are mentally unwell, where we say that the person lacks insights into what's going on with the person. So in that case, it's somebody else who is going to observe that thing for the person and now alert other people and try to convince the person to seek help at that point in time. So, like I mentioned, different signs, different things we should be looking for. And sometimes the person won't be the person coming to tell you. So it will be us who will say this thing and now help the person to seek the help. But if the person notices these things, right, and rightfully go for help, then that's something that way will also help as well. All right. So thank you very much. Yeah. So I think I will say hang on, until
all right.
Until it's time for me. I'm just looking at conscious of time, right?
Okay. I wish you might be able to keep hanging on until you are able to be asked a question, but
right, because that's something the part I would like to take on as well. But the thing again is that since it's mental health, I have a lot of psychiatrists here. So when they ask questions,
exactly, that's exactly what I wanted to say. That well, thank God, yeah.
So mental health questions, they can easily take that one up for me if I'm not here to answer.
All right, yeah, that's good. Thank you. That's good. Thank you so much. That's Dr. Ugo Chinwoba. Thank you so much. And I will, because of the time as well, I'll quickly move to Dr. Vicky Audu Nzekwe, and she will be talking to us about mental health, stroke, mental illness, everything, and the types of mental health that we have in the community. Dr. Vicky, can we hear your voice, please? Please unmute.
Yes, you may.
Can
you hear me?
Very well. Loud and clear.
Brilliant.
All right. So
I'm going to try and work backwards to where Dr. Chinwoba left off. So perhaps it'd be useful to know what mental health is in order to understand what mental illness is. And in order to do that, I'd like to use something that we all recognize. So, for example, physical health, for instance, because a human being is made up of different aspects. And we recognize that for someone to be healthy, you've got different areas of your life. It could be physical, it could be social, it could be spiritual, it could be mental. Okay, so for instance, physical health, somebody who is healthy may be that they've got no symptoms. So something like a headache, for instance, can be caused by something very simple like being too tired, not sleeping enough, or being hungry. Is the brain's way of telling the body that I need to rest, or I need food, or I need water. So it's a symptom of different things. It could be something very simple that can be sorted easily by eating. Or it could be a symptom of something more serious. Is that maybe a bleed in the brain or a tumor in the brain that requires more specialist help? The same thing when you have a symptom like headache that can vary in terms of severity, depending on what's causing it, from the very mild to the very severe. Same thing for mental health as well. So you can have symptoms that are mild and symptoms that are severe. So you don't actually need to have to be admitted to a mental health hospital for people to recognize that you're mentally unwell. So what is mental health? It refers to the cognitive, behavioral, and emotional well-being. It is all about how people think, how they feel, and behave. And people sometimes use the term mental health to mean the absence of a mental disorder, which is not necessarily so. So therefore, looking after one's mental health can preserve a person's ability to enjoy life. It can also make one more involved in reaching a balance between life's activities, responsibilities, and efforts to achieve what we call psychological resilience. The very simple definition of mental health that I like is one by the World Health Organization, and it defines mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. So, like I said, mental health is not just the absence of a mental illness. All right, so when one is mentally ill or mentally unwell, I'm just working now towards where Ugo left off. What are the types of mental illness? So Dr. Chinwoba has kindly described some very major symptoms of mental illness for us. What are the names we refer to those categories of symptoms in terms of our medical terms? So what do we call them? I think if I were to go through all the categories of mental illness, we'll be here for the next 3 days. I mean, you can open a whole library on the classification of mental illness. And the two most recognized classification of mental illness will come from the World Health Organization again. They've got something we call the ICD, the International Classification of Diseases, which is in its 10th volume currently. The 11th is soon to start in about 2 years. We've also got another main one we professionals refer to. That is the American version from the American Psychiatric Association, the Diagnostic and Statistical Manual. I'm not going to go through all the categories or all the listed mental disorders in those 2 volumes. I'm just going to mention probably just 7 broad categories. And I'm not saying this is exhaustive, it's just the most recognized forms of what we would probably say sometimes enduring mental illness or severe mental illness. So one of the ones people might recognize would be psychotic disorders. And Dr. Chinwuba has rightly mentioned about people having abnormal beliefs. But in addition to abnormal beliefs, which are called delusions, there are other symptoms that we call hallucinations. So it could be that is, and it could be in different modalities. So if one has a visual hallucination, that means there is like a kind of an experience without any stimuli. If you're looking at the screen right now, you can see different people. You can see me, you can see Dr. Chinwuba. You've got like a source of, there's something in front of you there that you're seeing. In visual hallucinations, there is no external stimuli, but you're seeing things that other people can't see. Same thing, you can have auditory hallucinations where you can hear noises or voices that other people can't hear. And you can have hallucinations in other modalities. It could be taste, it could be feeling, it could be different things. So those are what we call psychotic symptoms. And they can occur in different conditions, like schizophrenia would be the most recognized type of psychotic illness. There are so many types of psychotic illness. I'm just going to stop there for lack of time. We've got another broad category, the mood disorders. Now, mood, as it implies, has to do with how happy or sad we're feeling. And like I said before, using the analogy of a headache, it could be something very mild. Most of us will feel sad when unfortunate things happen, or when we've been hurt by someone, or when we've lost someone. We do feel sad. It is a normal part of life. Same thing, people can be depressed, mildly depressed, and won't really need any form of treatment or medication treatment. It could just be talking therapies or talking through that, whatever situation you're going through with someone. But then there's also the other end of the spectrum where you would need to be admitted to hospital. So that's like a major depressive disorder. So you can have disorder depression, as a mood disorder. You can also have what we call bipolar affective disorder. This used to be called manic depressive illness, for those of us who've heard of that term before in the past. So this is where people swing from one end of the spectrum to the other, where they can be depressed today and in the next few months be extremely happy, elated. When someone, it's okay to have it. I think the normal thing is to have a balance where your happiness does not really impinge on other people's rights, or you're not taking things to extreme. So when people are too elated and sometimes can also be depressed, they're said to have a bipolar affective disorder. And then the other broad group where Dr. Chinwuba started are the anxiety disorders, where people can get really, really anxious. And this can include illnesses like generalized anxiety disorder. You can have panic disorder, agoraphobia, if we've had them, all the types of phobias that we've heard of, claustrophobia, fear of closed places, agoraphobia, fear of open spaces, other specific phobias like phobias for spiders or phobias for water, different types of phobias that we can have. And then there are the stress-related disorders, as well as obsessive-compulsive disorders, where people have very intrusive thoughts into their minds or their brains, and they can't get rid of these thoughts unless they perform like a certain physical ritual. It could be like, I have the thoughts of contamination. Everything is dirty. I need to wash my hands 50 times. Otherwise, something bad is going to happen. And then that kind of takes over their life, and they can't lead a normal life. So that's just an example. It can cover a lot of different things. That's obsessive compulsive disorder. Now I'll move on to another broad category, neurocognitive disorders. And I can't help but talk about this one because this is my area of specialism as well. I'm an older psychiatrist, and I look after a lot of people with dementia. This is where it falls under the neurocognitive disorders. So you have dementias and different types of dementia, like Alzheimer's dementia, vascular dementia, Lewy body dementia, where it's not just the memory that is affected, unlike what most people think, but it also affects other higher functions, including ability to recognize people or recognize things and places for what they are, ability to actually plan and execute. Say it could be something basic like cooking, forgetting the sequence of cooking. You start to boil the vegetables first, and then you put the meat at the end. It doesn't cook, so you lose all those abilities you've had before. So that's in a nutshell dementias. Then we've got another category, the personality disorders. Now, you and I both, we all have our different traits. You can classify yourself. I would hold up my hand and say, I've got like an obsessive compulsive trait, not a disorder. This is a difference now. So you have traits, but not a disorder. You could have like, I don't know, if you're someone who people, well, I'm not referring to anyone in particular, but some people like to, some people can be very bombastic, and they like to fixate on what they've achieved. They want to just talk about themselves all the time. And people might say, this person's probably got a narcissistic personality trait. Now, when you take that to the extreme and it begins to impinge on what other people around you are doing, and people are say, no, this is more than what you would expect of a normal person to behave, the way a normal person should behave, then that becomes a disorder. And then you've got the emotionally unstable personality disorder, where people kind of feel they don't value themselves. They have short-lived relationships. They can, everything is either black or white. You're either good or you're bad, and it can switch. You can just switch the next day. Their emotions are unstable, so they've got this mental anguish they want to escape from, and in order to do that, they start to hurt themselves just to give them some relief. All right, so I won't go into all those symptoms, but that, in a nutshell, that personality disorder is another category. Then the last one I want to mention is addictions. So it's not just addictions to alcohol and drugs. It could be addiction to other things as well, like gambling. So these are the main types. I haven't exhausted the list yet, and I said I could hold forth for hours, and I don't think you'd like me to do that. So I'm just going to stop here at this point. Thank you.
All right, thank you so much. Thank you. I will also quickly like to move to Dr. Peter. Recently, a research review. You wanted to say something, Dr.
Oh, just I'll be taking my leave now, okay?
Oh, yeah. Thank you so much. We really appreciate your coming in.
Yeah, it's just like we put the cat before the horse.
It's all right. Thank you.
All right, okay, all right. So I'll catch up. You're going to record this, I would say.
Definitely, yes.
Okay.
All right. All right, thank you. All right. I'll quickly move over to Dr. Peter. Recently, a research review was conducted as part of the Racial Disparities in Mental Health Project, which was commissioned by NHS England. Their findings suggested that Black and minority ethnic communities are comparatively at higher risk of mental ill, stroke mental health, and disproportionately impacted by social detriments associated with mental illness. So the question here is, why are Black people disproportionately affected with mental health? Dr. Peter, okay, please.
Thank you very much. Yes, I think.
All right.
I think can you hear me?
Yes, we can hear you. Thank you. Great.
So just following on from the previous speakers, the mental health is a complex issue, and sometimes it can be quite difficult, and particularly in our community, Black community, it's something that tends to occur behind the scenes, and for several reasons, it's not something we speak. It's not something we've come to embrace and tackle and address it. So sometimes when it happens, it's something that tends to happen under the shadows. I reflect on my experience growing up from Nigeria, within Nigerian community, and there is this perception that certain mental health conditions are due to, are explained by other things, either from religious perspective or other reasons. I know, for example, in my place, there's something they call a wanje, and when I started psychiatric practice, I reflected on my experience growing up, and I come to realize that a lot of our people that were said to have spiritual problems are actually struggling with mental health conditions. So I suppose what I'm trying to say is mental health is or mental illness, it's real and is something that happens in our communities, but it's not something we easily speak about. And I think that's probably one of the problems. But generally speaking, like any other health condition, there are most likely to be multifactorial reasons or factors. Now, over the years, what psychiatrists and scientists have tried to do is to answer the question of why. So are they biological? Are they things that we inherit in terms of genetics? Is it something that can be passed on, say, for example, from parents to their children? Or is it something that is mostly influenced by our environment? Or like you said, wider socio-economic factors? And a lot of these questions still remains elusive. There have been a lot of progress made in terms of finding out why mental health problems. And I'm talking about in general, in every group apart from the Blacks. So there are some conditions that are clearly more prevalent. They are commoner within our ethnic groups, within the Black communities. For example, in the UK, things like psychotic disorder, it's something that appears to be very common within our communities. And reports suggest that admissions for schizophrenia tend to also be common among our communities. But of course, there are other conditions as well. One of the difficulties really is because of the attitude and our culture, and the lack of data means that it's very difficult to say, even in research studies, what they find is that the data that are available are not always very robust. And that's sometimes because of the small sample size. So to address the question why, so one of these reasons is biological. Some of the conditions are just more common within our communities. But there are also, like you mentioned, there are wider social factors. Social factors like poverty racism, discrimination, those adverse conditions, they do have significant impact on mental health. And it's not just about developing mental health problems or mental illness. It's also about ability to receive support, the care and the treatment that we need. And so those are some of the other things that we have. So it's not just about developing those conditions, but it's also what happens when our people present with mental health difficulties. How do we get to a point where we will seek help or seek advice or seek support from the services? And I know normally, or in most cases, we'll probably talk to our family members and talk to our friends. And until now, where the awareness appears to be relatively low, most people will say, well, get on with it. And a lot of our people will not seek service. And one of the things that's happened recently is that some of our people, for different reasons, cultural reasons and so on, will not seek help in time. So they tend to present with mental health services in crisis. So some of the admissions tends to be during crisis situations. And what happens in those circumstances is that they end up being detained, being compulsorily admitted to hospital. And with other associated factors, aggression, and so on, which can impact on the care that we receive. It can impact on the experience that our people have through the journey, I mean, in the journey through the mental health system. There are also issues around the criminal justice system. A number of our people come into contact with mental health services through the criminal justice system. And as we are also aware, the BME communities, particularly Black communities, are overrepresented within the criminal justice system. Now, different reasons for that, which obviously those are things that can be discussed another day. But from my personal experience, and I can talk about the time I work with the police, the understanding that our people, or some of the services have about the behavior of our people, can lead to some misunderstanding about how they handle our people. I mean, there are clear examples there where, a response can be disproportionate in terms of having 10 police officers to restrain one person in the police station, or even Section 136 suits. And of course, there's also the issues around stigma. It's a big issue because, as I said before, it's not something that is easily discussed. People have different perceptions about it. Some people feel, it's about weakness or weakness of the mind. And there are some religious aspects as well, because if you belong to certain religious groups, then it can be misconstrued in certain respect if you were to seek help, or to admit that you're struggling. Maybe you are expected to pray about it and by faith get it resolved. But these are other things. So, and there's also other services, other things that we experience: exclusion, marginalizations, inequalities in access to services. And this is very, very common, particularly with people within the refugee communities and asylum seekers. So these are quite range of issues, but I think in summary, my presentation is there are biological or genetic factors, and there are also wider determinants around inequalities, around stigmatization, not accessing services on time and only in crisis situations, not understanding how services work, and the barrier actually that we have between our communities and the services, not having proper linkages within the services. I think these are some of the attempts, I would say, to answer the question of why. Thank you. Hello, can you hear me? Hello?
Yes, thank you, thank you, thank you. All right, thank you so much. I'll quickly move to Mrs. Shade Shoguwawa. Hello, ma.
Hello.
Yeah, in our Black communities, mental health problems are rarely spoken about, and this can be seen as in a negative light. And this can discourage a lot of people in the community from talking about their mental health and may be a barrier to engagement with health services. So the question here is, why do Black people always feel ashamed of talking about their mental health issue? And what are the impacts of this mental health on the individual, the family, and the community?
Okay.
All right.
Number one, it's not going to take 5 minutes. So you must be ready for about 8 minutes. But I'm
putting this across to you because I know you've worked with a lot of people in the community as well. So yeah.
Yes, Dr. Oke has mentioned a few of the things I was going to talk about. But why do Black people feel ashamed? In the course of working with different people, both professionals and those who are not migrants and otherwise, what I tend to find is the stigmatization is the biggest problem. And for me, I link it 2 ways. It's our culture, how we see mental health. How do Black people see mental health? Some cultures, where some of us come from, we see mental health, those 2 words, mental health, as the extreme of mental health. There's nothing in between. So if that is the extreme we're talking about, then that people think mental health is, which is madness, complete madness. To accept that you have mental health is something that would not be seen in the community. If we're going to be honest now, in the community, it becomes a stigma. This person has mental health problem. I'm going to give a little bit of an example, one example, and people might agree or disagree. In some cultures, when you want to marry, they'll go and look at where you come from, where that partner comes from. And we are very aware of situations where maybe people have died of depression or they've killed themselves, and the family would actually refuse for you to be married into that family because they think, yes, your children are going to be this. You cannot marry into that family because that family carries a stigma that to us is unacceptable. Now, bearing that in mind, to come into this country, and I'm looking at it from migrants who've come in, I'm looking at it from established migrants who have been here, and they know the system, and young people. I find that speaking to a number of people, they don't want to be seen and labeled as mental health. We have in our communities, it's about we keep our business to ourselves. We don't want everybody to know our business. So we don't talk about it. In not talking about it, because that's what we think, people will see that we are that extreme, madness, and you do anything, the community looks at you like, oh, it's got mental health. So there's lack of understanding of what mental health is. What is mental health here? Which is very different from where most of us come from. So there's lack of understanding. And because of the lack of understanding of mental health, people refuse to seek help because they have, in quote, other priorities. For example, you're looking for work, what is regarded as mental health here? To you, that's not mental health. what you regard as mental health is different. So there's lack of awareness. There's also lack of awareness of the services that are provided, or lack of trust of services that are provided, where you think, even if you are aware, would your information be safe with them? And because of lack of trust, of course, you're not going to go either. So talking for people who come in, you think, oh, if I tell someone, is it going to affect me in A, B, C, D, E? So you don't discuss it. Then you move to the established community. People ideally who should know about what mental health is. We've lived here for so long and we know what it is. But the same stigma subconsciously still stops us from accepting that actually, you know what, I'm depressed, but I can get help, I can get support. And when we don't do that, it manifests much further down the line, which could affect a whole lot of things, really. So sometimes we know, or sometimes we think we know, but we actually don't know, because I'm learning some things on this today myself. So we have established people who know, but because of our culture and the stigma, they won't do anything either. They'd rather not, and not talk about it and come out and say, you know what, I've been in your shoes. You need some help, and don't be ashamed. Then I come to the young people. Our young people are more clued in and more aware of mental health. Their thinking is different. Their attitude is different. The ones that I've spoken to, I've had sessions with young people where they've actually said, can we have session on mental health? Now, and I'm talking kids who are teenagers. Now, what do we normally in our culture do when people say something around mental health? We're expected to be strong. And because we are perceived as strong and we're expected to be these strong people, the strong Black man, the strong Black woman. Even I'm guilty of it sometimes when we ask, many years ago, when people say, so how are the kids doing? You say, well, they can only be well. I haven't asked them to work. All they need to do is study. Why wouldn't they be well? Yes, thank God, they're fine. But the kids that I see now, they have issues that are so different from ours that we should pay more attention to. But they stop talking about it to the adults, because back home, when they go into their homes, what we're saying to them is, wait a minute, what's the big issue? Just study, get on with it. What's your problem? That's what we say to them. So in effect, gradually we stop talking about it and we end up with problems down the line. Now, I'm going to go quickly to what's the impact in just a few sentences. The impact of not discussing this, not coming out, is isolation, and we pretend. I came up with something called behind the smile. We pretend everything is all right, but it is not all right. And then it presents itself much more negatively down the line. But because we have been deemed to be this strong group of people, even our culture says that, we're strong, we can get on with it, nothing phases us. I'm not saying that's a bad thing. I'm just saying also there's situations or circumstances where we need support, which because of our cultures and sometimes because of our religion, stops us from going ahead and seeking help. And because also the community itself is not coming out and saying, it is okay to have mental health problems. It is okay, but there is support. And because once we start doing that, we start to remove the stigma, which we need to address. Effect of that on an individual translates to the family, isn't it? Because once it affects one person in that family, it affects the whole family. And once it affects the whole family, if we look at it another way, it affects the community, because if the presentation of the symptoms or, is further down the line, 5 years down the line, it affects the community. That's where you have the overrepresentation in mental health. But maybe they could have had the support much earlier on that would have addressed the problem. But we don't until it gets too late, like Dr. Oke said. That's my 5 minutes. Thank you.
Thank you. Thank you so much. Thank you. Yeah, because of time, I'll quickly like to move to Dr. John, please, can you unmute anyone that is not? Thank you. I would like to quickly move to Dr. Sam Best. I call him Pastor Sam. So Dr. Best, can you unmute, please? Dr. Best. Hello.
Hello.
Aha. Okay, we can see you. All right. Yes. So your take now, please. You know what you're talking about?
Yes, what am I talking about?
About the treatment. How is it easily accessible?
The treatment?
Yeah, on mental health.
Well, I would like to go back in time from what other people have said, so that my discussion will line up with the topic that we have, which is the awareness of mental health in our community. That was the topic that was sent to me. It's just on the spot of the moment that I was hearing mental health and mental illness. So I will veer on the side of what I've prepared for, which is mental health. Okay. Like what Mrs. Shongowa said, whenever you mention mental health, people think about the extremes of having madness and having mental disorder and having a mental illness. They are two different things. Mental health, as Dr. Zekwe defined, is well-being, a state of complete well-being. So that is what I'm going to talk about when we experience this thing, before it gets into the situation where it becomes a crisis, where it becomes so difficult to treat, and where we have to go through the system in other alternative way, like detention and being arrested and being restrained in different ways. So that is where I'm going to talk about in terms of treatment. Most of the mental illness are caused by stressors, that is things that cause stress in our life, and sometimes due to traumatic experiences we've had in childhood or even as we are growing up. And when these stresses become too much on the brain and on the mind, we can then dip into situation of what we call mental illness or mental disorder. At the time that we experience the stressors and the traumas, that is the point we need early help. And most of the help will come from the home, from the parents, and sometimes to an extent from the community, from the small groups. And that is the area of letting people to be open, being able to counsel people, even whether it's religious or other aspect. We should be able to have people who people can turn to and talk to confidentially. And that's one of the big issues that we have in mental illness. That is the issue of confidentiality. That is very, very important in the treatment of mental illness. People should be confident to be able to say, I'm stressed, I can't cope. Or they'll be able to say, I'm so traumatized by this event, I am so down, I don't know what to do. Our youths from this time should have access to that. Now, just like physical health, you tell people what to do to maintain that health. So what I want to talk about is what people should do to maintain health. Most of the things, the symptoms that we mentioned, they all happen in normal people. Normal people can have isolation, hallucination, or hearing voices when they are falling asleep. When they are waking up, people can hear voices. People can be sad. You can be down because of bereavement. That doesn't mean you are depressed or you are psychotic. So for mental illness, these symptoms that even normal people experience, for mental illness, they would have experienced it for a long time. And also they would have experienced it in such a way that it begins to affect their functioning and the functioning of others. So to deal with that, the first thing is talking about it, creating awareness about it, so that they will know, people will know that I'm stressed, I can't cope. Let me deal with this thing now before it becomes a mental illness or mental disorder. The other thing you can do is exercise. Exercise is very good for the body and for the mind. Apart from exercise, the other thing you can do to deal with your mental health and maintain a well-being is exercising the mind. You read books, you kind of entertain the mind with whatever you can lay your hands on that are of good reports that you can read to help your mind, instead of reading junk when you are stressed and when you are experiencing trauma. If in the event that it tips over to a mental illness or a mental disorder, my advice is not to give what medication or this medication to treat. My advice is that you seek professional help. You can call people like us who are psychiatrists, and we will be able to signpost you or help you with the system and show you how the system works. Because mental illness is a taboo in our community, like the stigma that Ms. Chongoa was talking about, sometimes it is difficult for us to avail ourselves with all these things. But if we can go to basis and start from scratch and begin to educate and begin to talk about this thing and begin to be open about mental illness in the Black community, then we will go a long way in not only being healthy in the mind, but also maintain our well-being. And I will stop there. Thank you.
Thank you, Pastor Sam. Thank you so much. While we were having the discussion, one of our experts came in. He came in from, can everybody hear me?
Yes.
Oh, okay. All right. He came in from another meeting, and I would like to introduce him to the panel. And he is Dr. Tammy Datubo. Dr. Tammy, please, can you unmute? And we would like to see you, please.
Hi, can everybody hear me?
Oh, very well. Thank you. You're welcome to this panel. Please, can you tell us about yourself and do your own presentation as well, please?
Yeah, my name's Tammy Datubo. I'm a consultant in older people services in Hartlepool. Right, so I think I've been brought in last to kind of like summarize the whole thing. So I'll take us back to how this Zoom meeting on mental health in Black communities actually started. It started actually on the 7th of June, when myself, Tolashe and Ngozi, I think is her name, we attended the Black Lives Matter rally in Middlesbrough. And I think after that rally, I was speaking to Tolashe and Ngozi, and I was telling them that I was faced with a lawsuit, you know, that I was going to be sued simply because a friend of ours, a Nigerian friend of ours, you know, was having some difficulties, and, you know, I thought it was stress. Now, being a psychiatrist, I think I used the professional word, mental health. So mental health could be involved. And everything hit the roof. I was accused of trying to break the Mental Health Act and do all sorts of things, and what I tried to point out on that day is the problem we have of stigma within our Black communities. You see, because in Nigeria especially, there's a binary concept. It's either you're crazy or you're not. Now, when people are crazy, they see them walking on the road half naked and doing all sorts of things. So that's the concept that people have in Nigeria of mental health. And obviously, some people also think too, yeah, if somebody is mad in their family, what is the hope of the children, down the line? So in those countries, there's no concept of this classification that Dr. Nzekwe mentioned of mental health. That is totally alien, to our people. In fact, even as a medical student, to be honest with you, it was alien to me. And we know that even the psychiatrists, even today, are sometimes faced with stigma, But as a medical student, I think I got some very good training from the only psychiatrist in Port Harcourt in those days, the late Senator Dr. Martin Zielo. I think I asked him once, how do you actually understand when people have a mental disorder? Because I can't understand it, And what he said to me was that people will come with physical disorders. It's quite clear. Now, if they don't have a physical disorder, but they cannot explain their symptoms, then you should suspect a mental health disorder. Because there's no word for depression or psychosis in most of the languages that we have. So these concepts are totally alien to our people. So I remember during my youth service, I looked out for this. And you find a lot of people come to you with, they can't describe their symptoms. And, sometimes they talk about internal heat. Oh, what's going on? They have this internal heat and all this kind of thing. And you dig deep, you realize that, look, there is some form of mental health illness. But then when you try to address it with them as a mental health disorder, the stigma kicks in. So people shy away, except those that you can hold and educate, then they'll, take medication, and then, we could treat them, successfully. So as most of my colleagues have spoken about, why is it important, especially for us in the United Kingdom, to understand about mental health disorders? First, that we know that there's a risk of psychosis, in Black people that is 7 times more likely to occur than in white people. And also, as Peter has mentioned, detention under the Mental Health Act is 4 times more likely to occur in Black people than white people. There's also a high rate of drug use sometimes in Blacks more than whites. And although white males tend to have a higher rate of what we call suicidal thoughts, they think about the suicide, but actually it's the Black males who actually complete suicide more, And what are the factors, again, that contribute to these mental health disorders? As we mentioned before, the stigma. So most families will not agree to bring people, for treatment. I know of someone who had so much stress, after childbirth, but would not seek care, had to travel to Wales to be with family, leave the children with the husband and travel to Wales, because the family wanted to cover up and hide things, But she spent more time away from her children, which could have caused more problems. Then again, we think about the socioeconomic inequalities. There's a lot of unemployment in our societies. There's as a result, a lot of poverty in Black societies. There's lots of homelessness and even overcrowding. And again, there is quite a lot of refugees who come from the Black minority ethnic groups. So a lot of these people have also faced difficult situations that also lead to, post-traumatic stress disorder and, anxiety. So for me, so personally, what do I think we need to do? I think we do need to increase the awareness and literacy amongst the Black people about mental health, including all aspects of health and social care. We need to create awareness to tackle stigma, so as to avoid that severe deterioration, so that people are caught early. So people don't have to go through the Mental Health Act, because you tend to go through the Mental Health Act or be detained if you are a risk to yourself, if you are a risk to other people, or if you have deteriorated so much in your mental health that you need immediate treatment. Now, this can be avoided if we proactively deal with things, So we need to try and tackle that stigma. We need to also improve services available that people can jump into, or people can find. I know I've had to refer some people for psychological support, because I didn't know that this was possible. But again, the other thing that might be required is training for our healthcare providers around, cultural psychiatry, or how people, kind of respond, and the kind of mental health amongst Black persons. Some people like to pray, and if you say that you heard from God, then the white psychiatrist will detain you. But some of us actually, have that kind of ability to probably speak in tongues, or hear those things, which are not a part of a mental health disorder. Then another thing I think we need to have is culturally sensitive facilities for, treatment of short and long-term mental health conditions. So I work in Hartlepool too, and one of the things that I argued about once was when I wanted to detain someone from an Asian background, and there was no care homes in the area that could even make a halal meal. So it therefore was a struggle to put this person in a place where they would not be able to cope at all. So also our facilities actually need to be more culturally sensitive. And then research is a long, long way. Because there's not enough research, we find that the burden of mental disorders in Blacks, is grossly underestimated. So there really needs to be lots of research in mental health. But what the Black Lives Matter has done is create a possible change in policies, procedures, and services. And that'll be good for all of us. But again, there's a WHO slogan that says there's no health without mental health. Now, all of us will, go for a jog, try to cut our waistlines and things and think about our physical health. But as Dr. Sam Best mentioned, you have to also think about your mental health and what you have to do. And I know there's a song that Bob Marley used to say, and it says something like, emancipate yourself from mental slavery. Yeah, Black Lives Matter was like, the knee to the neck. But what about the mental slavery of the Black man? Because that is what is causing the stigma. The sad thing is that, slavery did not start in America. Slavery actually started in Africa. I come from the south coast of Africa, and I mean, sadly, I know my people, sold slaves and unashamedly took, the names of the traders they dealt with and things like that. So we have lots of Wests and Browns and George, which is not our native name. But I think what that has done to the Black society is that it has created mistrust. So the average Black man does not trust the next Black man he sees. And until we can break those barriers of trust, because even if we leave Nigeria and come to the UK, you find that, it's not called racism, but it's called tribalism, and tribalism is worse than racism, if I have to be honest. It is deadly because our average Black people will not help their own brothers or sisters, based on the concept and fear and impressions that they have of them. Now, the white skin has united the white man, through times of slavery. The Scottish people survived in America, and that's why Donald Trump's father managed to, build what he had. Why can't our skin unite us? Why can't we trust each other? Yeah. Because we have quite a lot of psychiatrists in the NHS. We have quite a lot of doctors who want to help. But until you reach out to us, until you're able to stop being afraid, until you're able to stop worrying, until you're able to stop believing that a white doctor might help you better than a Black doctor, until we really understand that, look, mental health, as my colleagues have said, is not a crime, we will continue to keep going round and round in circles.
All right.
Yeah. Thank you. And like I said, Black Lives Matter, we'll sort out the policies and procedures, but this is a time for us to try and tackle our mental health needs and move forward. Thank you.
Thank you, Dr. Tammy Datubu. We will definitely come back to you. I will like to hand over to my colleague, Ngozi Sylvia Ochuba. Ngozi, are you there?
Yes, I'm here.
All right, it's over to you now.
I'd like to say thank you to Dr. Tammy as well for that insight that he's given. Working in the community as a VME navigator, one thing that I know that I have come across is meeting a lot of people who feel the fear of admitting that there is something wrong. I've spoken to a few people of African descent and people in the Asian community, and the moment I mentioned mental health, I've had 1 or 2 cases where someone said to me, I'm not mad. It's that fear of being labeled mad, or that fear of it going into their records. So I have someone on this panel, Sadia. Sadia said, she mentioned about trauma, and with the kind of people that I work with, the participants that I work with, I always find out that there's a history of trauma that is not being spoken about or not being, there's absolutely no opportunity for them to talk about the traumas that they've been through. So I wanted to put across a question to our doctors in the house and ask if they would describe to us some of the issues that are common among the Black community in terms of mental health, and which ones are the most dangerous ones.
Can Dr. Vicky undo that, please? Hello.
Dr. Vicky?
Dr. Vicky, are you still with us?
I am here. I am here.
All right.
I was just asking you to unmute me.
Oh, sorry about that.
Sorry.
All right.
Right. I'll just go back to what Dr. Chinwoba said before he left. So he described what we call signs and described what he calls symptoms. Symptoms as subjectively experienced by the patient is what is important here, rather than the signs the professional observes in the patient. So when you ask which is the more dangerous one, I think it depends on the perception of whoever is experiencing that symptom. So I can't say someone, I'll give you two examples. So someone who has undergone, say, female genital mutilation, or a military person who's witnessed lots of deaths in his field of work, who would you say was more traumatized? It depends on that person's perception, and it depends on how well the person copes, or what the sort of resilience the person has to cope with that stress. And it also depends on genetics as well. So what Dr. Ugo just briefly alluded to was there are different types, different causations of mental illness. And it's a combination of both nature and nurture. So nature or biological factors will include genetic risks. So there is actually some truth to the African culture of looking through family history to see whether they want their children to marry into certain families, because certain illnesses run in different families. So just like you have certain cancers run in different families, you do have certain illnesses that are more common in different families. So if you add a combination of those genetic factors, mix it up with nurture, so social economic status, availability of jobs, access to money, good education, good jobs and ability to earn, a lack of, or add that to stigmatization and racism, that can tip someone into developing a mental illness. So yeah, so someone who is experienced bullying in school, or someone who's been physically abused, or somebody who's witnessed people dying in the field, can develop different symptoms. They could have what we call just a general anxiety. They could have what we call a post-traumatic PTSD, post-traumatic stress disorder. Some people can actually even develop a psychotic illness, and it could be related to what they're experiencing, what they are seeing. So, and some people can as well become depressed. So there isn't one, I would say, that was more significant than the other. But of course, smacking a child at home, you wouldn't compare to actually somebody who sets out to physically and emotionally abuse a child. That would have a more severe and long-lasting impact on a child in comparison to correcting somebody, telling somebody off, or even smacking people as it's culturally accepted in African communities. I'm not sure if that answers your question. But...
Yeah, it does. It definitely does. Because the next question was I was going to move on and ask about social determinants and things that we feel like are the determinants in terms of mental health in the Black community. But you've mentioned them. You've mentioned about work. You've mentioned about earnings, stress, family life, and a few others. I wanted to give an opportunity. Sorry, go on.
No, that's absolutely fine.
I wanted to give an opportunity to some of the people we have on this panel to ask questions if they have any. So you can unmute yourself and ask a question if you have any.
Yes, thank you very much, our doctors on the panel, for such insightful talk you've given us. I just want to give a comment and then ask a question. Of course, defining mental health has been debated for a long time, where some people actually look at it through the lenses of the hedonic perspective that looks at just happiness, and others look at it through the lenses of the eudaimonic perspective that encompasses psychological well-being. But then the argument here is that mental health is affected by a number of factors, including cultural variations, individual assessments, and emerging theories. So this has got an impact on early detection, and Dr. Datubo alluded to this, that early detection of mental health issues is critical. So the question is, how do we support our societies to support the early signs? I know I've been involved in some research that has actually investigated the use of some tools like the GMHAT. I don't know if you've heard about the General Mental Health Assessment tool, where we thought that if we create a simple tool that can be used not only by the experts in mental health, like psychiatrists or doctors, but by people who actually interact with people on a daily basis. Think about teachers for children, think about, let's say, GP surgeries, to be able to ask the right questions at the early point so that these signs can be detected, and then people can actually be called before they actually get to an acute phase. So my question still remains that how do we empower our communities to be able to detect these early signs so that those that need help can receive that help? That's one. Then the other comment is about multimorbidity. I come from a public health background, and apparently there's a problem of multimorbidity. And you realize that most of the people suffering from multimorbidity would have a mental health condition as part of their package, depression, psychosis, or other things. Now, the question is, we know that we need to develop evidence, as Dr. Datubo actually alluded to this. And there is a lot of funds that are being given to actually support research in this area. Now, I work from the university and I've been leading some of these research projects. So my question is, to what extent are our doctors and psychiatrists willing to engage in the co-creation of this evidence, and what channels can we put forward to actually involve them in let's say, collaborative research, collaborative funding bids, and so on? And if they are willing, I'd be really happy to take this message back to my colleagues with whom we do some research at Teesside University, and then start to forge a way how we can work together going forward. Be able to co-create the evidence that is culturally sensitive, and it could actually support policy development that best benefits our people in the BEM group.
Oh, is that a question for Dr. Datubo?
Okay, should I go?
Oh, all right, yeah, you can go, because he mentioned your name.
Okay, so early support. I always, I work in dementia services also, and one thing I always tell families that when they expect this and they expect that is that, look, if you've seen one person with dementia, you've only seen one person with dementia. And it's almost the same thing with mental health. If you've seen one person with a mental health disorder, you've only seen one person, because everybody has different characteristics and different features. I always feel that for certain people, the bar should be lowered, right? So yes, we talk about our research, our tools like HADS and things that we use, but again, those are not culturally, sensitive, So a lot of information actually comes from the families themselves, who have to who have to trust to be able to provide the information, you know, and believe that, look, this is in the best interest, you know, of their family, you know. And that's why I said the bar has to be lowered rather than wait for someone to be really, really ill until the person needs to be detained. When there is that suspicion that something is not going right, you know, that is that trip to the GP, you know. And I think some GPs are actually making those referrals, you know, quite easily, especially now. And in terms of research, like I said, there's so much that needs to be answered. There's so many questions with very few answers. And I think, I don't think I speak for only myself, but I'm sure all the doctors on the panel, we would like to be involved, you know, in any research that is available that will help, you know, our people. But we bear in mind that while most tools are developed for Caucasians who tend to speak one language, right? We bear in mind that even amongst us, even as Nigerians especially, we have about 600 languages or something like that. So there is that diversity, you know, even amongst, you know, the Black African community. But, you know, if families are able to work with us, you know, I'm sure we could develop quite a lot from research. Does that help?
Yeah, and sorry, let me just ask something. I'm here now to take any question. If can you hear me?
Welcome back. Yes.
Right, okay, I just arrived at my workplace. I'm here. I'm okay to take any question on the sign and the symptoms as well.
Sorry, can I ask a question? Your presentation, don't go.
Can I ask a question?
Okay, yeah. So yes, it's just I'm available to take questions from because
someone wanted to ask a question.
And symptoms.
Yeah. Okay, go on.
My name is Bart Akelemo. I have comments to make later, but I want to ask 2 questions first before I delve into any other I would like to say. To the psychiatrists and experienced mental health practitioners on the panel, do you think that a diagnosis of depression or schizophrenia is in whites is different from blacks? So do you think if 2 persons are diagnosed of depression, would the depression in a white person be different from depression in a black person?
Yeah, can I answer that one?
I'll ask the other question.
Okay.
Second question, do you agree that religion is a big barrier to early detention and intervention of mental health disorder or illness in blacks, especially Nigerians? Especially Nigerians. Do you agree that religion is a barrier to early detention and intervention of mental illness in blacks? Those are my 2 questions for now.
Okay.
Thank you.
Dr. Ugo, before you go on, please, if you can just summarize the answer within 2 minutes or less. Yeah, because of time. All right, thank you. Right. Go on now.
Okay,
thank you.
Okay, so I will start with the symptoms we have in the white and the black, right? Something like schizophrenia, which is a mental illness. Right? Every race suffers from schizophrenia, or sometimes the presentation might be different. How they present, when I say presentation, might be a bit different, right? Like where you are asking somebody questions. Some people might really come out with how they are feeling and tell you, this is how I'm feeling. But whereas in some, what they are not able to describe some of those symptoms, right? An example is, because I remember when I did one paper when I was doing my master's in the University of Cardiff on personality disorder. We have personality disorder here, and we do have personality disorder in Nigeria as well. But the presentation is different for both, because when you say culture now affects how they present, how they really come out. And I asked some psychiatrists in Nigeria, do you have personality disorders here? What they told me, no, we don't really see them. It's just the textbook stuff. But people will describe a personality disorder as people that look for trouble. But here, the presentation is different. They cut themselves, they do this, they threaten you that they are going to jump, and they take overdose of tablets and call for an ambulance, which will come and pick them from So the presentation is different, because when you don't have such amenities, you now see that they present differently, right? And the other thing again that for instance, somebody in Nigeria might say, "Oh, I nearly died." But here, when you say die, once you mention die, they will see it as you being suicidal. Whereas in Nigerian context, die, we just say, we use die for a lot of things that way, a lot of sentences that we make. So might actually not be suicidal, but because you use that word, then here they might think you are. So your culture, the way you say it, might even kind of make them think that you are more at risk than you actually are. So sometimes we now have to tease out and tell, look, this is the language they use a lot. So it doesn't necessarily mean that this is what the person meant, right? Okay, so that's where also the other thing you talked about is where religion. Yeah, religion, we know. Sometimes with religion, we do get late presentations where people believe that maybe praying and this thing is going to solve the problem. Because we know that this is a condition that involves chemical changes in the brain or the mental, and we know that you need this medication or this to help correct those chemical changes, which the illness, which kind of cause the illness in itself. So, and the other thing again is that because we know part of treatment for us, we know we can use medication and we can also use talking therapy. Talking therapy is where we use psychology. That is where religion may play some kind of role in helping, because when you have this group support and so on, just like somebody counseling you, giving you these things, it helps as well. But there are where things like for schizophrenia, we know that you need this medication to help you to correct those chemical changes in the brain, which cause you to have those abnormal thoughts and perceptions. So you really need the medication. Sometimes people present very late where they think that, oh, praying for the that's going to help some problems. So in that case, where you mentioned about religion being an obstacle, it could be an obstacle as well. But there are things that we know that maybe hope, somebody supporting you, because religion can also be a kind of counseling for us in a way. Things like maybe mild depression and so on. Having hope and noticing people coming praying with themselves, that's we know can have its own so positive as well, but we can't just depend entirely on religion, saying that that's what's going to get well. Okay, it's always good to seek the right support.
Yeah, can I just add to that? Just like Dr. Ugo said, you know, the causes of mental health problems tend to be multifactorial, just like my colleagues have alluded to, and that the treatment for most of us, we tend to use the model of biopsychosocial. So biological, meaning medication and tablets and things like that. And as Dr. Ugo said, the psychological talking therapies and engagement, but also the social support that the person has. And, you know, it's quite different between blacks and whites. And for me, the idea of religion can be, as Dr. Ugo has said, a double-edged sword, because some people need that hope. Yeah. You know, and that hope is supported by religion. Yeah. While where practices are that, you know, they will not do anything else apart from pray, you know, they will not go and seek any other treatment or take medication, and then they deteriorate. That is where religion, you know, works against the whole thing. So for me, it's a double-edged sword, but you know.
Can I contribute to the religion part of it?
Yes.
Yes.
Okay.
Yeah. Religion is not the problem. It's the administrators of the religion that is the problem.
Okay.
I've had several cases of people who have been mentally ill. Because I'm a psychiatrist, I was able to use both systems, both prayer and Christian counseling, and also be able to signpost them to where they can get professional help. So this is where this topic we are sharing now is very important, which is awareness. I will encourage Brother Tolashe, this topic is something that we can cascade to the churches to educate the ministers and the pastors and even the congregation. We've done this in some meetings before, and it has been helpful. So this awareness needs to cut across board. It's not a question of scapegoating one side, saying religion is a very good thing. Jesus Christ said the sick needs a physician. And the Bible also says that if you have any problem, that you should find somebody to confess your faults to, and which is talking therapy. And there are a lot of biblical correlate to mental illness or mental health in the scriptures. So if people avail themselves of that and saying that there is actually biblical correlates, especially of psychology. I wrote an article of the correlates between Bible and psychology, and both of them are inclusive in themselves. They are not kind of exclusive. So I encourage that somebody who is of a faith should avail themselves and be aware of the mental illness in the Black community. Thank you.
Let me just come back to why I asked the question.
Okay.
I've worked with patients or service users who cut across Black ethnic minority groups. And one thing I found out, especially for those experiencing early mental health problem, is a denial, which is based on religion and social cultural. And I've gone to assess somebody at home where the mother said, "Not be my picking, God forbid bad thing, now your family." It was almost when I came.
I mean, see, the thing with religion and psychiatry is a big topic on its own, right?
Good.
So, and the thing is this, if you ask a white man, he will tell you it's not.
Doctor. The reason I asked whether diagnosis of depression is different in a Black man and a white man is because often a time what we lack and what we should drive, which I think this is what this is about, is education.
Education,
awareness.
Education, yeah, awareness.
Like
across board.
Our people need to be educated. I have a simple way of telling patients or family what mental health is. I say, it's like you having high blood pressure or diabetes. It's there.
It's there. Yeah.
But it's only when you don't look after yourself, when you don't do what you need to do, that is when your condition will deteriorate. And like Dr. Tammy said, when you go deteriorate, you end up being sectioned and being taken to hospital. But what I think we need most, far up and above everything, is education and create that awareness in our community. The systems Especially here, I'm not talking about Africa. Africa is a different ballgame entirely. For those of us who are here, the system is there. You can even choose to see any psychiatrist you want to see, or any practitioner you want to see. You can make your choice. The system are there, but people are not accessing those systems because of these barriers that we have created already.
Yes.
And how do we break down those barriers?
All right. Thank you, sir. I think at this point, we will soon be rounding up. And I'm so happy that we are so much, we have embraced this awareness. But before we round up, do we have anyone? Is there anyone that would like to ask any question again, please?
Yeah, there's a hand already there. Yeah, Galax, okay. Galax tab 2. Is it Mr. Ankata? Do you want to ask a question?
All right.
Oh, is he gone? Okay.
Galaxy, because we want people. Okay, all right. Hello.
Hello.
All right, we can hear you.
Can you hear me? Yeah, thank you.
Very clearly. Yeah.
What an amazing evening. Thank you to you all. Fantastic. The reason why I'm coming in is because for more than 5 years, I've been doing some awareness work in the Black community. I was actually involved in the BBC funded program of Time to Talk, where we went around churches. What have I learned? I have learned that exactly things you've highlighted. Our people are short of knowledge, basic skills of detection. They don't need a lot of science, high-wired science. They need the basics.
That's right.
Yes, and the other part of my learning is that we don't realize how valuable we are to our communities until you start to go to them. You will be overwhelmed, not by numbers of people, but by the opportunity of learning, what it is for our people. Our people are here, but most of them are still in Africa. If you know what I mean.
In the mind, yeah.
So they need us. They need us. Yesterday, a few days ago, I had a phone call from a friend of a mother who was beaten by his son. When I was called to be part of that process of helping out, I discovered that it is not the first time, it is not the third time, more than 5 times this young man has been doing it to mother, but mother is fearful to tell other people that her son is unwell. Until we came in, I was able to advise her to contact social services to refer herself as a vulnerable adult. Last night, she sent me a message of appreciation that she didn't know she would have. If she knew what she knew now, she would not have suffered. It's only then that she understood, and she was told that her son is using mental health services. But what happened, her son was still in detention. Until it came out that she knew, then she contacted the police, and then they took the young man to hospital. There was no evidence whatsoever. The mother didn't know that the young boy is under mental health services. So anyway, my contribution is, I think this is a fantastic initiative, but our people want us on, they need foot soldiers. We need to go to churches, to mosques, and to every party. I think there should be a 5-minute silence for for people like us to stand up and talk a little bit about mental health. Thank you.
Thank you so much. This is just the reason why we have created this discussion. It's for us to be able to have deep knowledge of mental health in our community, and especially in the Black community, where we don't really want to talk about mental health at all, and it's really affecting a lot of people negatively. And that is why we have brought in so many experts. But we'll soon be rounding up. But before we round up, we have somebody who is whom I really respect so much in our midst, and we cannot go without letting him say one or two things. And he is the person of Dr. Tugs Shoguawa, and he's also one of the elders in our community as well. Dr. Tugs, what do you have to say about this? Because I know you are also working with other people in the community as well.
Yes, for the sake of time, I just want to say thank you for this. It's been very helpful. If anything, it's opened up a lot of questions that we need to address and answer. The issues that have come up is really more about awareness, stigmatization, refusal to accept it in our communities. There's been issues about access to services, a bit of inequalities in access, in services, or services that are best for our people, which are a lot of issues. Issues of faith had come up, which we cannot run away from. I've heard Dr. Best saying issue is not religion, but administration. Whatever the language we use, it is an issue. People see our spiritual leaders almost as mini gods, which is bad. And just as families don't accept mental illness or mental ill health, this happens in our communities as well. There's been some issues about culturally sensitive services. But the message that seems to be coming out as we should see ourselves as ambassadors, foot soldiers, to be able to go out into our communities and have community engagement, use the opportunities to raise awareness, education, and try to remove the stigmatization that is attached to mental health. We all have a part to play. And when I say community engagement, that is using the different avenues. And one area that has come up is using our places of worship, both mosques and churches, and where we have leaders that are respected in their individual communities will be very useful. So I think this will be a beginning of many other seminars to come up around mental health, or mental health and mental illness, which I think is be very good. And I'll be looking forward that we have such, either you want to start looking seminars, picking different cohorts, say for example, cohort of leaders, religious leaders first, then looking at places of gatherings and all that. So once again, thank you. I'm ready late for another meeting, but it was something just I couldn't get out of, which was quite interesting. And thank you for all the contributors. And thank you especially to Sadia, who was really filled the chat group with so many opinions and
information.
Very wonderful person.
I see you as a mental health advocate.
Yes.
Because I look at that group chat, your contribution, you've taken about 9/10 of the whole page. So I'm sure you'll be somebody that will be able to contribute to future seminars. Thank you once again.
Thank you, Dr. Tugs. And Sadia Nakimera, if you don't mind, we'd like to work with you as well. We have, just to mention this before we round up, we have this forum that we have just set up. It's called Black Communities Alliance. This is set up for us to have one voice like this in case we have anything that we are going through. And we are using this opportunity to also invite all our experts into this forum. And in case anybody, if anyone has any question or anything to discuss, you can contact us through our email address, ivision043@gmail.com. And I want to use this opportunity again to say thank you to all the everyone, all the participants that are here today. Especially our experts, Dr. Tammy Datubo, Dr. Peter Oke, Dr. Vicky Audu Uzekwe, Dr. Best, and our mommy as well, Madam Shadi Shogowawa, and to everyone, and again to my colleague, Ngozi Uchuba. Until another time when we'll be coming your way. My name, hello? Yeah, my name is Tola Shidayova. And until another time, I say thank you, and I appreciate everyone. Thank you. Bye.
Thank you.
For now. Yeah.
Thank you, everyone.
Bye, and thank you.
Thank you.